This is a special three-part podcast, Our Broken Healthcare System, presented by Dr. Nicholas Biasotto. The opinions expressed by Dr. Biasotto are his own as an independent practicing physician. This is part one, Where Are All the Doctors?
Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hello, everyone. This is Nick Biasotto, host to the podcast, Medical Society of Delaware, Delaware Healthcare Reality. But before we start, I'd like to just do a little bit of housekeeping. A lot of people are asking, how do we access our podcast? Well, you can listen on multiple platforms. One is Apple, then we have Spotify, YouTube, Amazon, TuneIn, Alexa, iHeartRadio, Player FM, Samsung, Podchaser, and also now on SiriusXM, Pandora, and Podbean. I particularly like following it on Podbean under Delaware Healthcare Reality. Please send any questions, comments, or ideas for future podcasts to healthcare.reality at medsocdel.org. That's healthcare.reality at medsocdel.org. As we all know, the healthcare system in the United States is broken. So I decided to look into this and find out what the possible causes are and is there any solutions that can be offered. I will be doing a three-part series on this issue. The first part is going to be today, and that is, where are all the doctors? As you know, I'm a primary care physician and practiced for 45 years as a solo practitioner, the good old family doctor, up until 9 years ago. I was seeing 40 to 50 patients a day. You may say that I was making a hell of a living, but that was not the case. With the continuing escalation of the cost of running a practice with employee salaries, benefits, insurance coverages, supplies, and utilities, I was barely making it. And some weeks I did not take a personal check. Besides being exhausted at the day's end, I was considering retiring early. However, I love what I do in helping patients and was sad to think that that would end. My options were few. I could find employment as a hospital-based physician. I could retire. I could hire physician extenders, nurse practitioners, but my patients always wanted to see me if that would happen. I could become a concierge practice treating a limited number of patients who pay a yearly fee to have 24/7 access to me, timely appointments, house calls, extensive office exams, and time with me for preventative discussions about their health care. Going back to the first one, hospital-based physician, I'm not sure I could do that. Yes, much of the burden of being in a practice, a solo practice, would be offset by working at a hospital. They would take care of all the problems that we have and all the hassles we have from the insurers as well as the government mandates would not be bothersome to me in that position. I could retire. I did not want to. I could hire extenders, but it's found out that most patients want to see their doctor. Yes, physician extenders are important, but some of the studies are showing that physician extenders may actually cost the system a lot more money. I could become a concierge physician, which I did. I chose that because I wanted to stay in the practice and I wanted to care for people as I did when I first started. I had few patients when I first started. I made house calls. I was really part of their family. I'd go there, take care of them, and come and work in the office. Well, I got busy rather quickly and couldn't do some of the services I love to do. I taught many medical students, interns, and residents over the years of my practice because I also, besides a primary care physician, I was also medical director of a wound care and hyperbaric oxygen center for Christiana Care. On asking some of these younger physicians, the newbies coming up, what were they going to do upon receiving their medical degree and hanging their shingle, and less than 10% said they would go into primary care. Citing the large loans they had accumulated for their medical degree, in the range of $250,000 to $300,000, and seeing what my work week was like, and knowing how primary care is reimbursed, they were going to, especially that paid much more, or they would have to be paying their loans until their 60s. I can understand their attitude. However, what happens to the foundation of medicine, the primary care doctor? We're seeing our foundation crumble. Primary care doctors are going away. To find one is rather difficult. And if you do, to get an appointment with him during an illness may take weeks to see him or her. That's not the way it should be. So where are people going? When they're sick, they're going to an urgent care center, which is rather costly to go to, or they're going to the emergency room in the hospitals, which is definitely a costly thing to do. I could have substituted a nurse practitioner, but I mentioned that their training is not the same. We have somewhere in the range of 26,000 hours of training where we can hang a shingle, and nurse practitioners have less than 6,000 hours of training before they can hang a shingle or call themselves independent. Most nurse practitioners, and I teach them also, have said they do not want to hang a shingle on their own. They simply want to work with a doctor side by side, which is a good thing, because if they're in a bind, they have somewhere to go. So how did I address this problem? And how do we address this problem? The problem is the medical system is broke. What do? Studies have shown that every dollar spent on health care, $9 to $10 in savings can be attributed to having a good primary care doctor at the helm. Why? He could take care of your problem. He may not need you to have a further test because he knows what's wrong with you. For example, chest pain. You may think it's a heart attack, but there's lots of reasons for chest pain. And yes, primary care physician knows you, checks you, and says, it's nothing, it's a rib, it's a chest bone, it's irritated. But how do we build this foundation in medicine again in America? It is said that by 2033, there will be a shortage of physicians in the United States of approximately 140,000, making access even harder to achieve. Also, can we lessen the burnout by eliminating many of the hassles faced by doctors today, from the prior authorization burden to other bureaucratic issues facing doctors in the United States? For example, EMRs, pay-per-performance, approvals for drugs, applying every 3 years with the government to tell the government where we belong or where we are. I haven't moved in 45 years almost, so I am not changing. Why do I have to do this? We got a lot of things to do yet to make things better. If we address the issues of rebuilding a foundation in medicine, i.e., we know very well that the foundation of medicine is primary care. We know very well that the primary care doctor saves the system money. Then why can't we pay the primary care doctor an adequate reimbursement? Why can't we do it that way? For example, I may see a patient who needs a joint injection for whatever the reason. Now, I use the same needle. I use the same medication. I put it in the same knee as I was trained as an orthopedist. Primary care doctor may get $25 for that. An orthopedist may get $125 for that. So what is the difference? We're both doctors. We're both licensed. We're both trained. Matter of fact, I trained with orthopedists to do that particular procedure. So why does the insurance company not allow us to get adequate reimbursement? Number two, I am an osteopathic physician. I learned how to do spinal manipulation in college, 4 years of it. I will do manipulation on a patient that comes to my office to give them relief for some musculoskeletal problem. I get a report back from the insurance company that you're not a chiropractor. I know I'm not a chiropractor, but I trained probably more than a chiropractor on how to do this. As a matter of fact, the chiropractic school branched out from the osteopathic school of medicine. So why is there such a poor reimbursement to the primary care doctor? Now, listen, I don't want to say that I haven't lived a comfortable life, because I sure have. But I would like to be paid fairly for what I do, as well as all the primary care doctors that I know. Now, if I become a primary care doctor in a hospital setting, I'm obliged, and I'm going to discuss this in my second part in this series, I am obliged to use the hospital's facilities. I send a patient for an MRI of their brain and suspect of having a brain tumor. I send them to the hospital because I work for the hospital. Hospital costs maybe $2,000 for that brain scan. Went on the street, same magnet, maybe even the same doctor who happens to be moonlighting in that place. It's $850. Why? I don't know. But this is why broken medicine in this country. Other ways we can solve this problem, maybe standardized testing. MRI costs this everywhere. Boom. That's it. 1, 2, 3. I will later get into what I think the hospital's part of the broken system is in my next series. After that, I will be attacking the insurance industry, and I will be attacking the insurance industry. I know we all need it. We need insurance, but the way it's run and the profits that are made in the insurance company, especially in the administrative department, are excessively high. So stay tuned. Anybody who feels strongly about this subject, please, let's get some questions about this. Let's talk about it. Let's see what we can do to overcome the problem. And that will solve a lot of problems in this country. I often wonder, is there a one-party payer system that would help? That's been debated for many years. But everybody I talk to about this says, well, who's going to run it? The government? Well, anything the government tends to run tends to get messed up. I said, well, they've been running Medicare for quite some time, and it's been doing okay. So why can't we have a system similar to that? Yes, it will take capitalism out of the picture, but it will work. I think we're only one of 42 countries in the world does not have one-party payer, or it's not their health care is not free to the public. Why can't we do that? We're a country of innovation. We're a country that is ahead of the game in a lot of things. And why can't we make our medical system better? This is Dr. Nick Biasotto. I'm completing this podcast. I hope you listen. I hope you bring up subjects to your legislative membership, both at the state and federal level, to see if we can correct the problems in America. Remember, a cracked foundation means that the house is going to fall.
This is a special 3-part podcast, Our Broken Healthcare System, presented by Dr. Nicholas Biasotto. The opinions expressed by Dr. Biasotto are his own as an independent practicing physician. This is part 2, How do the hospital systems make so much money?
Hi, this is Dr. Nick Biasotto, the host to the Medical Society of Delaware's podcast, Delaware Healthcare Reality. And as I promised, I will be doing a 3-part series on the broken hospital system in the United States. I've already done part 1, which hasn't been released yet, on how the doctors are affected by this broken system. And this is our second in a series of 3 on how hospitals make their money. And my resources for this particular discussion are from Medical Economics, NPR, and Pharma Magazine, and Elizabeth Rosenthal, who had a very good article in this regard. So here we go, ladies and gentlemen. How do the hospital systems make their money? But let me review from what I've talked to you in the past about. Though the best in research, the best hospitals, and the best diagnostic equipment, and cutting-edge technology, the U.S. healthcare system is not working. The U.S. system faces significant issues such as preventable medical errors, poor mortality rates, and lack of transparency. Also, finding a good doctor, the high cost of care and lack of insurance for low and income families has led to social and economic discrimination in healthcare services. Due to a shortage of physicians, nurses, and specialists in hospitals and health centers, Americans are unable to get the optimal quality care they need. Add to this the lack of universal health care insurance coverage. 16% of the United States population are flying bare, so to speak, with medical expenditures becoming increasingly unaffordable for marginalized communities. So to get the help these patients need, they rely on ER or medical aid facilities for their health care, obviously driving the cost of care even higher. Nationally, chronic illnesses such as diabetes, obesity, heart disease, and cancer contribute to the high cost of care, particularly during end-of-life times for the patient. It is said that a person may generate the largest cost to the healthcare system in the last 2 years of their lives. The National Academy of Sciences found that the United States has a higher rate of chronic illness and a lower life expectancy than any other high-income nation. That's a bit scary, isn't it? Lastly, to this, high administrative costs contribute to these soon-to-be unsustainable healthcare costs. As mentioned in the 3-part series, I've talked about the primary care system and how this is the foundation of a good medical process. However, primary care doctors are suffering, and they are few and far between. And if this foundation is collapsing and cracking as it is, the whole system will fall. Lastly, before I address how our hospital systems make such large profits, consider reinforcing the foundation of our system by encouraging, through education, our overindulgent society, allowing them to live longer and healthier. What does that mean? Decrease overeating. Decrease alcohol use. Do not use illicit drugs. Stop smoking. All of these things will decrease the cost of care in the United States, and yes, you can play a part. And now, part 2. How do hospitals make their money? Hospitals make their profits from many reasons. 1. Patient services or fee-for-service, bills to patients or other insurers for medical procedures, surgeries, hospital stays, and ER visits. 2. Government programs may pay a bit less than private insurers, but the volume of Medicare and Medicaid programs is voluminously large, which contributes to a large increase in income for the hospital setting. 3. Insurance contracts with hospitals negotiating very high rates of reimbursement. 4. Elective outpatient payments, i.e. surgeries, such as orthopedics, cosmetic, etc., or imaging studies, such as MRI or CT scans, outpatient procedures such as colonoscopies, cystoscopies, and others. 5. Pharmacy and lab services. 6. Grants, donations, and other endowments. 7. Research grants in academic hospitals. And 8. In investments and real estate gains. So let's dig a bit deeper into the categories of how do nonprofit hospitals make so much money. Industry experts agree that the most profitable hospital systems make a lot of money even if patients are unable to pay. It seems that their prices can be generated by charging very high rates for medical procedures such as major surgeries and for medications prescribed such that a single dose of aspirin or Tylenol may cost up to $20 a pill. And hospitals may receive 500% of what Medicare allows through the Center of Medicare and Medicaid Services, CMS, which sets the prices for all medical services for any visit or procedure done. Throughout the nation, a big hospital system has become very profitable though they are considered non-profitable by themselves, while patients are burdened by out-of-reach medical prices, increasing deductibles. In turn, the hospitals lowball employee salaries while establishing better contracts from suppliers, and many patients face $5,000 to $10,000 after their hospital stay due to deductibles. And this is from NPR News. It should be noted that hospitals charge very high prices for services that may be obtained outside the hospital, such as imaging in a facility outside the hospital may cost $800 for an MRI of the brain, when if done inside the hospital, that same MRI may cost $2,000. Why can't we standardize pricing? We have talked about how hospitals, through negotiations, receive higher payer or insurance company payments from insurance people, both independent and government, who will pay amounts much greater than allowed by government regulators or CMS. And even though hospitals are or may be nonprofit, they can still generate large profits due to their tax-exempt status and their excessive charges. Generally, they pay little to no taxes and yet manage a myriad of profit under the nonprofit umbrella. So, through legal maneuvering, government neglect, and large lobbying groups, they continue to fall under a tax-exempt status classification as 501c3s, a non-profit tax-exempt system. They are non-profit, however, in name only. These maneuvers usually occur in large hospital systems, while the smaller systems, with far fewer negotiating powers, are barely surviving or going out of business. How many of you all know of a small hospital that has had to fold because they could not compete? Government or private insurance payouts are lower in rural or small hospitals, and it seems that the IRS turns a blind eye to all of this. Large hospital systems claim they charge more for care because they spend so much time, effort, and money treating the poor underinsured patients. However, much of their charges and income to aid the poor pale in comparison to their tax-exempt breaks. I think it's now a good time to take a break because I need a sip or two of water, and I'll be back shortly. This is Dr. Nick Biasotto.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Hi, this is Dr. Nick Biasotto. I'm back from my break regarding discussions regarding our healthcare system in the United States and how broken it is. Another way hospitals make large profits is what they make from dispensing medications. Big tax-exempt hospitals abuse a little-known federal program to charge high markups on medications, sometimes up to 7 times or more than the medications cost them. They get away with this by exploiting the 340B hospital markup program. This government program was designed and created in 1992 to help patients access more affordable medication. Today, this program has become less about patients and more about boosting profits to hospitals and for-profit pharmacies. The program works by providing medications at significantly lower cost to hospitals and lets them charge whatever they want for these medications. The hope is that they use this medication money to help the uninsured and low-income patients afford the care they need, but often this is not what happens because there is no oversight and 340B has strayed far from its safety net purpose and has become a way for hospitals to rake in big profits with little charity care to show for it. At the same time, hospitals have found loopholes to generate even more profit. More medication markups mean more profit for large hospital systems, pharmacy benefit managers, private equity firms, and big chain pharmacies. When hospitals can charge whatever they want for medications, we all pay the price, and those that need it the most don't seem to get it. 57% of all hospitals in the United States participate in 340B. In 2022, discount 340B purchases reached approximately $54 billion, and this amount has increased to this day. And the numbers of contract pharmacies have grown nationwide by more than 8,000% since 2010. And 47% of contract pharmacy arrangements are with pharmacies associated with one of the 3 largest benefit managers. But what about Delaware? Where do we stand on 340B? 6 hospitals in Delaware are part of the 340B program. There are 142 contracts between Delaware 340B hospitals and pharmacies nationwide. Only 50% of contract pharmacies are located in medically underserved areas. and 83% of 340B hospitals in Delaware are below the average for charity care levels. In Delaware, the charity care rate in 340B hospitals is 1.8%, when the national average is 2.5%. In total, hospitals in Delaware make 4.5 times as much from 340B as they spend on charity care. Wow, just a few of these things make you realize how our system is so broke and how our system is so broken. Add to this the last thing I want to mention before I go into one of our House bills that is being under consideration and has been passed, is consider the high compensations to hospital administrators. I realize that to run a company like a hospital is a big, big business, and it's a lot of work. But is it worth millions and millions of dollars to compensate the administrators? I do not feel that is fair. So what are we doing in Delaware to maybe somehow decrease the cost of hospital care in this state? Well, last year, the legislators in Dover passed House Bill 350, and it was signed by Governor Carney. It established a board to review hospital budgets and insist on budgetary restraint. Now, this board has been labeled the Diamond State Hospital Cost Review Board, and it's out there to possibly save us money. It's been formulated, the law's been passed, signed by the governor, the board is meeting regularly. However, Christiana Hospital is suing to stop House Bill 350. And why is that? As they say, it infringes on their autonomy. More to come on this issue, and I'm sure it's a hot topic that's being discussed on a daily basis down in Dover. We'll see where it goes. I don't know where it's going to go. I don't know if they're going to save money, but it's a great effort to see if we can save money in the state of Delaware for the high cost of care. This is Dr. Nick Biasotto, host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. If you have any comments on this podcast or any others that have been done in the past or in the future, please email us at healthcare.reality@medsocdel.org. That's medsocdel.org. This is Dr. Biasotto signing off. I will speak to you later.
This is a special 3-part podcast, Our Broken Healthcare System, presented by Dr. Nicholas Biasotto. The opinions expressed by Dr. Biasotto are his own as an independent practicing physician. Number 3, how does the insurance industry make so much money?
Hello, this is Dr. Nick Biasotto, your host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. This will be the last of a 3-part series that I've devoted to exploring the broken medical system in the United States. The first was a series of doctors and their understanding of what is broken in the system. The second was how hospitals make their money. And the last is today. This is how the insurance industry makes so much money. The insurance industry makes their money 3 ways predominantly. The first is premiums. This is their main source of income, where people and or employers pay annual or monthly cost for coverage based on expected health care costs, administrative costs, and a profit margin. The second is underwriting profit, also called risk management, where the insurers aim to collect more in premiums than they pay out in claims. This data is accumulated through actuarial science to estimate the risk of insuring a group or person, and they price their plans accordingly. If claims are lower than expected, they profit. 3 is investment income. Insurers invest the money they collect from premiums before they pay claims, and they invest in bonds, stocks, and other types of investments with even modest returns on large investment portfolios bringing in significant revenue. For example, the Affordable Care Act, also called Obamacare, it requires insurers to spend 80 to 85% of their premium income on actual medical care and quality improvement. The rest, 15 to 20%, can go towards administrative cost, marketing, and profit sharing. If they exceed the cap, in other words, spending less on medical care, they must issue rebates to those who have paid the premium. So tell me, when was the last time you received a rebate from your insurers? They inflate the premium cost to make sure they do not exceed the cap. Is the insurance industry inflating their premiums to generate large monetary gains? The simple answer is yes, but this depends on various factors, which are, 1, the rising healthcare cost. This is a big driver of premium increases, and these costs include hospital services, which you know are very expensive, and prescription drugs, which also are very expensive, physician fees, and technology, with these costs continually rising year after year, partly or mainly due to poor health of the American population. So insurers will pass these costs on to the consumers through higher premiums. And a company that you work for example, may have a very unhealthy group of employees. And the premiums for that insurance are going to rise. However, the days of a company paying the total premium for employees is gone because of the fact that many companies are asking the employee to pay more and more of a percentage of their premiums. Now, insurers are regulated to limit price gouging to an extent. As I have mentioned above, medical loss ratio, you can exceed the cap on medical care, the insurers will increase premiums to maintain their profit margins. Now, I did mention that a company you work for may pay a part of your premium. But in some smaller companies with fewer employees and smaller budgets, insurance may not even be offered, and or they may hire part-timers just so they don't have to offer insurance. And it is known that insurance market competition varies, so in some regions where there is multiple competitive insurers, the premiums may be in check or low. In other areas without this competition, like Delaware with a perceived monopoly, insurers can charge higher premiums with less pushback. Of note, compared to other industries, health insurance profit margins are not huge, around 3 to 6% on average. However, because total revenues are enormous, it still translates into billions of dollars in profits annually, with many arguing that the excessive administrative cost, marketing, and high executive compensation inflate the premium costs unnecessarily. I'd like to discuss the Luigi Mangione case that's going on in New York at this point in time. It's an individual who's being charged with the murder of the CEO of United Healthcare. Trial soon to begin. I don't know exactly when, but it will begin shortly. But the amazing part is that he has so many sympathizers that are contributing to his legal defense, because I'm sure they are disgruntled people who have had problems with the insurance industry in the past. Now, in no way do I condone taking any type of action such as this to argue your point. This is not to be done. I disagree with it 100%. And I hope everyone else that has a problem with an insurance company, they address it in a civil manner. So what is the bottom line of all of this? Premiums rise and insurers ensure a profitability, but regulation, rising healthcare costs, and competitive pressures complicate the notion that premiums are simply inflated for massive, unchecked profits. As you know, the system is too complicated and complex, so both real costs and inefficiencies in the system drive higher premiums. Are there solutions to this complex and costly problem? Well, I guess the answer to this is yes, but many changes in the system must occur. Since insurance premiums largely reflect health care costs, addressing the root drivers can help. And how's that? Well, we can lower prescription drug prices, negotiate prices, cap certain medications prices, etc. That may help bring down some of the costs. Hospital transparency, so that patients and insurers can compare costs between hospitals. We discussed this in part 2 of my 3-part series. And third, promote value-based care. Pay providers for health outcomes, not just services. This can make the patients, quote unquote, toe the line. Let me give you an example. You have a diabetic, hardly comes to your office, rarely sees you. He has a very high hemoglobin A1C, which is a gauge of blood sugar control over a 3-month period on average. And he presents to your office and his sugars are in the 250 to 350 range. Now, you could talk him into, put him on more medication, as we would probably do in this situation, but you have to have a hard and cold talk with this gentleman or individual. You have to say, you have to toe the line here. You have to lose the weight, follow your diet, exercise more, and the medicine will help, but it's not the end-all, be-all, and you do not want to have the end-all, be-all of diabetes. 4, how about administrative reforms and simplification by reducing complex billing and paperwork? Well, here we go with the prior authorization issue again, which I've beat down in the past, and I'll continue to beat down till I probably am beat down. Prior authorizations have cost the system a lot of money. Doctors' offices are paying a fortune to keep their staff busy trying to fight denials from the insurance industry and trying to get prior authorizations in general. This costs a significant degree of money to the offices, and I'm sure it costs the insurance industry quite a bit. Also, simplify the complex billing system that we have. I don't know if any of you have seen the coding system that doctors have to use. It's called the ICD-10 coding system. This system is the size of a very, very large, old-fashioned telephone book, if you remember what they were like. So it's hard to negotiate. It's hard to navigate. Maybe make it easier, less codes, make it easier to alert the insurance company of what the bill is going to be about. We need insurance market reforms. How do we do that? Expand subsidies for private insurance like the ACO, Obamacare. Give higher subsidies, give them more benefits to get an insurance plan such as this. You can also set up a public option, a government-run insurance plan to compete with the private insurers. Remember, more competition, lower premiums. Third, allow Medicare and Medicaid expansion to cover more people. Well, the baby boomers are coming up now and really hitting Medicare pretty hard. That's okay. We all need it, and we're all getting older. So far, everything's looking good. It doesn't look like we're going to lose Medicare in the near future. So it has been working to a degree. Medicaid is a different story. If you earn below poverty level, I can understand the need for Medicaid insurance. That's a good thing. It helps you out when you're in need. But when you're back on your feet, you're not disabled, you're back on your feet, you're able to work, get out and get a job. This could lower our Medicaid enrollments. Increase competition by making it easier to buy insurance across state lines. Now, as I mentioned earlier, the only insurer we have here in Delaware is Highmark of Delaware, Blue Cross Blue Shield. But what if we were able to buy insurance from Mutual of Omaha or some insurance company in Tennessee that offers a better price, a lower premium, and is competing with the monopoly that we have in our state? That would lower premiums altogether. And then, how about alternate health system models? Making fundamental changes to the system. For example, a single-payer system. Eliminate private insurance. Go Medicare, quote unquote, for all. Now, this has been touted recently as being pretty popular, gaining popularity. But a lot of people say they don't want the government to run the program. It'll screw it up. Well, Medicare's been running for many years, and it's still here. So it's working. Maybe it needs some tweaking, improvements, and more money to fund it, but that's the way it is. I think that we've invested in Medicare a long time of our life. If we're workers, we should gain something out of it. How about universal health care with tighter rules for private insurers? Maybe less compensation to executives and reduced administrative costs. That's a plan. How about giving patients more control? How about these health savings accounts? This is where your employer will take what you've allowed to be taken out of your pay to put into a health savings account, which is tax exempt. Now, maybe you could increase the amounts of healthcare savings accounts caps so that you can offer that and gain more money of that and use it to pay for pharmacy equipment, pharmacy supplies, other medical equipment, office visits, things like that. Encourage preventative care and wellness to decrease chronic disease impacts. I've been lecturing this for a long, long time. The United States is an overindulgent country. We eat too much, we drink too much, we do drugs too much, and we smoke too much. All of this leads to poor medical outcomes. And that's why we spend so much money in this country and our outcomes are still poor. So we need a great educational program to teach the people of America how to live right, what to eat right, not to drink to excess, do not smoke, exercise, things like that to get people healthier. Costs in the country will go down significantly if that happens. So I'm not giving up on education for the population. And last, technical and administrative innovation. Streamline the claims process. 2, expand telehealth to reduce unnecessary in-person visits. And last, AI and data analytics to predict and manage high costs of care in the United States. Well, I hope you have enjoyed my 3-part series. Many of this is all my research, and a lot of it is my opinion. If you agree or disagree or want to give your comments to this particular series, please, you can reach us at healthcare.reality at medsocdel.org. That's medsocdel.org. This is Dr. Nick Biasotto. Till next time.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitton. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.